Hey everyone, I'm Shawnta Jackson and happy Saturday. My purpose in life is to help people to help themselves and others. And today we are streaming. We are streaming live on both Facebook and YouTube. So please, I have a very important guest, a very special guest. And I encourage you to post any questions and any comments, and we will address them. So for today's topic, we're going to talk about HIV. We're talking about HIV/AIDS. And I think it's important for us to re-educate ourselves about HIV. Blacks, African Americans make up about 13% of the US population. However, of the, I believe it's like 37,800 and a little change. So of the 37,000 plus cases of new HIV diagnosis, we Black African Americans account for 42% of those new cases. And so I think it's important for us, again, to re-educate ourselves about HIV/AIDS so that way we can take care of ourselves and each other and our communities. And my guest, she is an public health HIV pharmacist, and her name is Dr. Cassandra Esperant, and she's in Florida. And everyone, please welcome my guest. And again, I encourage you, please do ask questions. Thanks. Hey, Dr. Cassandra, how are you today?
Hey, Shanta, I'm doing great. I'm so happy to be here with you talking about this important topic today.
Yes, thank you. Tell us a little bit about yourself. Tell us a little bit about, who you are. What is an HIV pharmacist? What does that mean? And why are you even choosing to pursue this work?
So, my name is Cassandra, as Shanta let you guys know, and I am an HIV clinical pharmacist. And at the end of the day, my life goal was advocacy. I remember being a little girl and watching the Haitian people in my community get sent back when our boats came, and I always wanted to be an attorney. So I didn't understand the concept of advocacy. So my heart's desire was advocacy, but as a child, I didn't know the difference between being an attorney and advocacy. So with that being said, I changed my career to pharmacy. And with that being said, I remember being 5 years old and watching the CDC say that Haitians cause HIV. And the Haitian people in my community marched to New York City to dispel this myth. And ever since then, this was definitely something that marked me mentally, that, made me interested in this career of pharmacy and this disease state of HIV. So what I actually do is I practice HIV at the AIDS Healthcare Center, and I focus on prevention. So that includes patients who are HIV positive, getting them on treatment, and also people who are HIV negative, ensuring that they stay HIV negative even though they're engaging in high-risk sexual activity by taking a medication.
Okay.
So that's who I am.
Thank you. Thank you so much. And again, everyone, thank you so much for joining us. And our topic today is HIV/AIDS. And we do encourage you to ask any questions. We do have a HIV pharmacist. And let's start with talking about, I want to re-educate us.
Okay.
HIV. What is HIV and what's the difference between HIV and AIDS?
Okay, so HIV is when you contract the virus HIV. So AIDS is when you never treat HIV and your CD4 count goes lower than 200 and your viral load increases to 200. So what that means, CD4 is like your white blood cells that fight off infections. So if they're low and you get an infection, it can literally kill you. And that's what AIDS is. And your viral load is the amount of the virus that's in the blood. So as long as you take your medication and it remains about less than 200 and your CD4 count remains more than 200, you will, live a healthy, long life because these medications are amazing.
Okay. And so HIV, human immunodeficiency virus. And just because a person has HIV, it doesn't necessarily mean that they will acquire AIDS. And from what I just heard you say, is AIDS is the medical diagnosis when your CD4 count is below 200, correct?
Exactly.
And once a person is diagnosed or classified as having AIDS, meaning that their CD4 count went below 200, let's say it goes up. Do they continue that medical within their medical records of having AIDS, or is it back to
Yes.
HIV?
Yes. As if you've ever went below 200, you will have that diagnosis of AIDS moving forward.
However,
Yes.
but your count you can boost your immune system and your count
Yes.
can go up, but you still
Yes.
have that.
Your count, exactly. Your count can go up, and once you get it under control, you will not transmit HIV to someone. Means undetectable equals untransmittable. And you can live, a healthy, normal life and engage in sexual activity and without transmitting it. But you would have to, maintain your adherence, which means taking your medication as your doctor tells you that you should, for that to, remain in effect.
Okay. And let's talk about a little bit about HIV transmission. So the bodily fluids that transmit HIV are what?
So it would be semen, right? So it would be blood and semen. Those are the main ones and also people who inject IV drug users. So if you're sharing needles, you can contract HIV that way as well. So a lot of times we forget about that because it's not only through sexual activity that you can contract HIV. And right now we're having an opioid epidemic. So that is a major issue that we're dealing with in society today. So we cannot forget this community. And HIV prevention also includes making sure our IV drug users get clean syringes as well.
Yes. And so you said as far as the bodily fluids, semen and blood. And so I assume that's because you work a lot with men, but there's also breast milk.
Yes.
And vaginal fluids, right?
Yes, vaginal fluids.
So semen, vaginal fluids, breast milk. So a mother can transmit the virus to her child usually it's during childbirth or breastfeeding, correct?
Correct. That's why it's important that women get their HIV tests. And, it's a requirement during the, medical, so from the OBGYN, that they make sure they ensure that they're HIV negative in order to prevent mother to child transmission.
Okay. And so again, just for the audience, blood, semen, breast milk,
vaginal fluids.
And then also, in addition to HIV, hepatitis is transmitted the same way as HIV.
Exactly. And something else I wanted to mention also, we cannot forget our sexually transmitted infections. That's definitely very important, right? So even though that you're taking HIV prevention medications, it's definitely important to continuously wear a condom because it only prevents HIV. It does not prevent you from contracting sexually transmitted diseases.
When you say what doesn't prevent?
The prevention medications.
Okay, yeah, so let's talk about those. So what are, educate us on the prevention medications.
Okay.
And who is it for and at what point do I take them or does someone take them?
Okay, so for HIV prevention, there's actually two medications that are indicated for that. There's Truvada and there's Descovy. So the first one, called Truvada, is indicated for everyone. Anybody who is having unprotected sex or had a lot of STIs within the last 6 months or so, they are, eligible for this medication as long as they are HIV negative. The second option, which is the newest option on the market, it's called Descovy. Descovy is only indicated for men and transgender women. Why? Because the studies were only done in that cohort. So again, with that medication, you take this tablet once daily and it would prevent HIV. There are instances when people take Truvada and it's called on-demand PrEP. So what does that mean? There was a study done in France called the Hypergay study. And with this study, what they said was you can take PrEP on demand as long as you plan your sexual activity. So let's say that you know that you have sex every Friday night, right? So you would take 2 tablets 2 to 24 hours prior to having sexual activities. Then you would have sex. Then you would take one tablet 24 hours after those first two tablets. Then you would take another tablet 48 hours after the first two tablets. And that would protect you from getting HIV. So there's a lot of people who are concerned with like bone issues and renal issues because it does have like a transient effect on your bones and your renal function. But the studies did show that everything reverted back to normal once the patient discontinued the medication. So, let's say, there's some people that, don't have sex, unprotected sex that often. Maybe it could be, we'll keep it real, right? We have our businessmen who, when they travel, they do step out on their wives. So if they want to protect their wives, this would be a way to take the PrEP without having to take it daily, since it's not needed daily. So this is
Or
something that needs to,
yeah, so I
or
definitely
use a condom, for sure.
right, for sure.
For
we
sure.
Should be, yeah, we
For
should
sure.
be. Yeah, we're not in a monogamous relationship, and if both if you and your partner have not been tested, and
Right.
you don't, if you haven't been tested recently,
Right.
and that means you don't know your status. So you should be using a condom until the both of you, I would suggest, until the both of you together have an HIV and STI test, and you can discuss your medical history and make your decisions moving forward together again, so you can take care of yourself and take care of each other.
Exactly. I agree. But then there's a lot of people who do not like to use it, unfortunately. And this is just like another layer of protection for those cases but I do 100% co-sign the condom because it gives you HIV prevention as well as sexually transmitted infections. 100%.
Yeah, and for women, for pregnancy as well.
Exactly.
And let's take a break really quick. I want to check in and see who's watching. We have Logan. And Logan, where are you? You're watching on YouTube, but what city are you checking in from? And Logan is interested in the link between HSV and HIV.
Go ahead.
So herpes simplex virus. I had to process it.
Right.
Simplex virus and HIV. Could you talk a little bit about that connection?
So when you have HIV and you have like a sexually transmitted infection, one of the reasons why it's very important to make sure that you get those sexually transmitted infections under control is that it makes it easier for you to contract HIV once you have a sexually transmitted infection. So what happens is you have increased inflammation, and that allows the HIV to insert itself easier. So it's multiple reasons. Not only can sexually transmitted infections potentially cause infertility, cause community spread, but STIs have been proving to increase the incidence of HIV infection. That was a great question, Logan.
Yes, especially so if someone has herpes simplex virus, whether they're performing anal, oral, or vaginal sex, if they have an active outbreak, they can have a sore, and that sore can be open, right?
Exactly.
So that makes it so thank you so much, Logan, for that. And Logan is checking in from Indiana, Fort Wayne, Indiana. Thank you. And we have In Your Ear Radio checking in from Las Vegas, and she's coming on later this evening, everyone. In Your Ear Radio, she'll be broadcasting live. I believe it's 2 p.m. Pacific time on Facebook and YouTube. And then we have Alfonso Mayo from Baltimore. He says that this is a mature conversation and this is our reality. And then he also says that we can slow the spread of the virus by using these preventive measures or don't engage in sexual activity. Yes, so definitely abstinence or choosing not to have sex. Of course, that's the only 100% way for us to prevent the spread of any sexually transmitted infection, including HIV.
Exactly. And one thing I wanted to add. So let's say that there's an incident where you had an accident, you got exposed to someone who has HIV, or you're not sure and you had unprotected sex, there's actually something called post-exposure prophylaxis. What does post-exposure prophylaxis mean? It means that if you take this regimen within 72 hours of having the unprotected sex with someone who has HIV or someone that you're unsure if they have HIV or not, it's a component of a medication called Truvada. It's Tivicay. This is also an HIV positive regimen. But if you take that medication for 28 days, it will prevent you from getting HIV. So let's look at it in terms of birth control or pregnancy prevention, right? So you would consider post-exposure prophylaxis as the plan B. So the plan B, you take it after you've had unprotected sex and you have a concern of getting pregnant. You take it within 72 hours to prevent you from getting pregnant, right? So let's say you finish your 28-day regimen and you're still engaging in that high-risk sexual activity. Then you would go on the birth control, right? And that birth control is what? It's the PrEP, the pre-exposure prophylaxis. So you would then start taking this medication once daily. So if anytime you get exposed to HIV, that medication would be in your system to prevent you from contracting HIV. So this is something that's very important and that a lot of people are not aware of. And one other thing I wanted to add is that PrEP is also for us as women. A lot of people are not aware of that. Like if you see the commercials on TV, it's always the men in those commercials, but it's definitely important that women take PrEP. The statistics actually show that 44% young women contract HIV more than young men. So with that being said, a lot of times women don't have the control of the condom use, so it's important that women empower themselves and protect themselves and, and try not to fall into that stigma, because at the end of the day, only you can control your own health.
Okay. And this is a really good conversation. So just as a recap, so there is, for HIV prevention, in addition to choosing not to have sex, and in addition to using a condom, there's also things that you can do potential exposure. And so you mentioned Truvada, and then there is Descovy. Is that what you said?
Yes, Descovy.
But Descovy is more for men who have sex with men and trans. Is that what you said?
It's for all men.
Okay.
Regardless of the whether it's men that have sex with men or if they're engaging in heterosexual activity. The only reason is because the studies were not done, so it's not indicated for women.
Okay. So that's the pre. So that's our pre, and
right.
Then for our post, that's our plan. So you were. So your analogy is just your traditional if someone chooses hormonal birth control. So right. That's the pre. That's the take it on a regular basis, and
exactly.
Then so. The post, that's our plan B.
Exactly.
And the post that someone will have to take it for 28 days in a row?
Correct. 28 days for about a month. So that's what the regimen, and that would prevent you from contracting HIV. So a lot of times. Mm-hmm.
No, go ahead, please.
So I was just going to mention that a lot of time when women have experienced rape, they usually give them that as a preventive measure. And especially these days, we have a lot of incidents of like human trafficking, and we're in the middle of a pandemic. There's a lot of intimate partner violence going on. People have lost their jobs. They're spending more time with each other than ever. So it's definitely important for our communities to be aware of these options.
Okay. And so Black women are a high-risk population for contracting HIV. Could you please talk to us and tell us what research says about that?
So in our community, as a Black woman, it's definitely important that we are aware, because as Black women, our Black men, a lot of the times, they're not only engaging in heterosexual activity, even though they don't consider themselves gay, they are having men MSM relationships, which means men who have sex with men. So does that?
Oh, your audio.
What does that mean? It means that they're bringing home HIV to us, right? So it's definitely important that we get empowered. So the studies actually show that the statistics, let me correct myself. Let me look at it to make sure I'm giving you guys the correct statistics. So when it comes to women, right, it's about 68% of all HIV infections come from men who have sex with men. And out of all the HIV infections, 53% are in our Black community. And like I stated before, 1 out of 5 women end up getting HIV. So it's definitely important that our communities understand this, especially not only our Black community, our Latino community too. Out of all HIV infections, Black and Latino account for 69% of all the infections. So what does that mean? That means that we need to be on PrEP. And there's a lot of stigma behind it, but we need to understand that stigma or no stigma, you can prevent it by taking this medication, and it does work.
So I think that so with any healthy relationship, there's trust, communication, and respect. And I think that we have to, even though we feel uncomfortable with having these conversations. So usually when I'm dating someone, you get to know them. And I ask questions. I ask about credit. I ask about a lot of different things. So I'm not shy. But then I also ask about, I really don't care about how many women you've been with. And my thing is, when's the last time you had an HIV test? Yes. And when's the last time you had unprotected sex? And I would prefer, and so some guys, they move so fast, and some women are so, and in this, I find it depends on what part of the country you live in. So for example, let's say I lived in Atlanta, Georgia. And so they say, the ratio of heterosexual men to women is very slim. So I could understand, I could see how some women, they don't want to cause any conflict and get themselves out of the pool for consideration for this man. And he probably has multiple women. And like you said, some of these guys are having sex with other men, whether it's anal or oral, and whether or not they identify as being gay or not, or LGBT. Yes. So I can understand that, but I encourage us as adults to have these conversations, but then also to have these conversations with our kids, and some people think that talking to their children about their sexual and reproductive health is encouraging them to have sex. But I beg to differ. And sometimes we wait when our kids are already having sex to have those conversations with them, when we could start having age-appropriate conversations throughout their lifetime, actually when they're younger. But I think when they're like in elementary school, it's more so bullying and healthy relationships, peer pressure, different things like that. But once they get of a certain age, I think it's important, because they're learning things from their friends, and they're experimenting, and we don't want them to get into a situation where it's something that we can't reverse.
Right. Shawnta, you and I both work in the public health field, and we understand, and we see it every day when we see that 13, 14, 15, 16, 17-year-old come in as a test entry, which means newly diagnosed patient. We try to get them on medication as soon as possible to get them undetectable, to prevent them from spreading it. So because we know it's happening, our youth is a huge community that's affected by this pandemic called HIV. I mean, like, it's so vital that we have these conversations and educate them and empower them before they even start experimenting. Because again, they are one of the top, groups of people that are getting HIV today. And because they think that they're young and healthy and invincible, a lot of times they don't get tested. So yeah, I agree with you completely. We have to be transparent and have these conversations and answer their questions to empower them to make the right decision. I completely agree.
Yes. So as far as so we have incidence. So incidence would be new cases, and then prevalence is just the overall amount of cases. Why do you think that the incidence, or the new cases of HIV are different amongst Blacks, African Americans, as compared to whites?
Okay, so let's take this back to history. Our community does not trust the provider's office. We don't go to the doctor. So we're getting tested less than ever. Like we don't get tested. I don't know if you're familiar with the Tuskegee Institute experiment. So
Tuskegee, syphilis
yes,
experience.
yes, they actually told a group of Black men that they were going to give them free health care. And instead, they actually injected them with syphilis. And even though there was a treatment, they never treated them. So that's definitely been a stigma. Just the other day, one of my patients came in to pick up his prescription, and we're going to compare this with COVID, because literally the same disparities that we're experiencing in COVID, you can extrapolate that to HIV. There's no difference. It's just that COVID is the pandemic we're in right now, and HIV is that other pandemic that we seem to have forgot about, but is still rampant, right? So he explained to me that, he wasn't interested in getting the vaccine. And, he brought up the Tuskegee Institute incidents to me. So we definitely have a lot of work to do, as people in the public health to, encourage our trust in our community in medicine. Because if we don't do that, the incidence is going to remain rampant and the disparity is going to remain high. And the point is you have to get tested. And if you're negative and you're engaging in a high risk behavior, you can take prevention. And if you're positive, you get on medication and you live a healthy life and you don't spread it to the community. So it's so vital that we empower and educate our community, because the white MSM community is, taking advantage of the PrEP and in high numbers, but our Latino and Black community, they seem to be lagging behind, and it's because of this mistrust. And as recent as in the ICE, right? Like they were actually sterilizing these women without their consent. So we don't even have to take it back to the Tuskegee Institute. We can, keep it current and current events. So again, because of these disparities and this lack of health equity, it's causing our community to have a lack of trust in medicine.
Okay, so we have a lot of comments. So we have Lorinda actually. So Lorinda is watching and from Chicago, and one of her original questions was what strategies are used to encourage infected individuals to take meds. So what we see on the screen is kind of like a follow up to that. And yes, and some individuals in our communities are skeptical. And Alfonso Mayo, he's in Baltimore watching. He wants to know, how do we build trust? But before you answer that, I want to backtrack.
Okay.
I want to add. So I asked you about, why do we see these disparities between Blacks and whites when it comes to HIV incidents and new cases of HIV? And so there's not one answer. There is not one answer. No. And I appreciate your response, and I don't disagree with anything that you said. So yes, we do have issues with trust. However, there's also systemic racism.
Yes.
And so think about in the Black community, the different stressors on a regular basis.
Oh, yeah.
So think about, we all know how stress impacts our body. So this is not just for HIV. This could be for any chronic disease or any virus, bacteria that enters in your body. So stress can compromise your immune system. And so if you're constantly stressed, if you're a Black man walking down the street, depending on the community that you're in, or if you're being discriminated against in school, or if you're in, just various type of environments, right? So, but this goes on for generations and generations. So that we even have, even maternal child health. Black mothers are more likely to die during childbirth as compared to white mothers. And this could be a part of medical care and treatment and lack of care. But again, the chronic stress, if you are continuously stressed throughout your lifespan, and if any virus, any bacteria enters into your body, it has a higher chance of succeeding and doing what it's designed to do naturally, and to take over or compromise your immune system even more. So I would like for us, and that's a concept in public health, that's like our basic, anyone who has taken a public health course, or if you're interested in getting a degree in public health. That's like a public health 101 concept. At the very beginning, there's this famous video about stress. So I kind of wanted to add that in as well. And there are studies behind that, and there should be more. But I just wanted to add that in. But back to Alfonso Mayo's question. In your opinion, how do we build trust?
In my opinion, is getting people in the healthcare fields that look like us. Like, for example, when I have a patient that comes in and they start on PrEP, I talk to them like I'm their friend. This is what I tell them. I say, hi, my name is Cassandra. I'm your pharmacist. Great decision on empowering yourself to protect yourself. And they kind of get excited, right? Kind of make it like a pep rally. And the next thing that I do is just let them know, look, it takes about 7 days for the concentration for a man to reach the level of prevention, as long as you're taking it daily. And then for a woman, it takes 20 days. Then what else do? I tell them the side effects. I let them know that about 10% of the patients experience side effects. And if they do experience side effects, worst case scenario, it lasts like a month. And some people it lasts a few days. And I let them know, the potential side effects are nausea, upset stomach, flatulence, which means feeling gassy. And I just like empower them, right? I make sure they know that I'm available. I actually have I actually, send them a link to the Instagram page. They can call, ask me questions. And a lot of times they'll call me right back because, oh, my friend said that this medication is for people with HIV. And then I have to explain to them, and I'll give them my, analogy of, plan B versus birth control, and they get really excited and they get empowered, right? Because again, the patient they're not sick, right? They're doing something to prevent. So we have an issue with retention. So building that relationship is so vital. And for me, having someone that looks like me talk to me about it definitely makes a big difference. So having, people in our community advocate about it, having this discussion, these are things that will help build trust, because at the end of the day, we got to demystify those myths, because it does work when you take prevention.
Yeah, and also with trust building, there's a lot of different titles, but you have peer advocates, you have people from the community.
Yes.
You don't necessarily have to have a college degree. You can be trained on HIV. You can take some courses, and you can serve as a volunteer, and sometimes a lot of paid positions. So community health workers, Alfonso Mayo has a nonprofit organization, and he's a decision maker. He's an executive director. And so when it comes to your funding opportunities and for your programming, that's a line item that you can include for community health workers, for you to actually recruit people from the community, whether it be the parents or caregivers of the youth that you serve. And you can have a program, a training program, and so we have to find these opportunities to create these opportunities as well, so that we can educate ourselves and people can educate their family members, like you said, and just even platforms like this. And also, I think it's important for Blacks, African Americans, to participate in research so that we can benefit from research.
Exactly.
Of course, educate yourselves, and you ask questions, and you have the right to refuse or withdraw from any type of research. And some research is social and behavioral. It's not always about clinical or taking some experimental medication. However, for example, Descovy that you were talking about, that was only tested with men. So that's why it's diagnosed, prescribed for men. But a lot of times, and just in general with our medications, even with COVID vaccine, just in general, a lot of the participants, the high blood pressure medicine that you're taking, if you're taking high blood pressure medicine, those participants were majority, most likely white participants. Exactly. And so it's been tested or studied, I shouldn't say tested, but studied on a certain population that doesn't include you, but you're a recipient, and you're prescribed the medication. So we also have to participate in the process as well.
And another reason also is a lot of us don't have insurance, right? But the beautiful thing about this specific medication is that the drug manufacturer actually offers it to you at no cost, as long as you're within 500% of the federal poverty line. So it would be given to you at no cost. And even if you make more than the requirement, there's another program that's funded by the government. It's called the Ready, Set, Prep program. So what does that mean? The only requirement would be is that you don't have insurance and you have access to this medication. And even our insured people, you have insurance and you go to the pharmacy and they tell you, oh, your copay is $1,000, your copay is $200. The drug manufacturer also has a copay assistance card that would pay for it. So there's so much help out there. Cost should not be a reason why you don't take this medication. If you're engaging in high risk behavior, it's so important. And there's a lot of help out there. And I know sometimes, you go to the pharmacy and you would just have to pick, the pharmacy that's willing to help you, because the same way you shop around for a car or a provider, you can shop around for a pharmacy, because there's a lot of different options of places you can go that would actually help you navigate this.
I have a controversial topic. So we have Mr. Jimmy Denson in Las Vegas. And he says we need a Black system of medicine / medical, because the white system of medicine is slick, deceiving, tricking Black and tricking Black and non-white people of color. And that's and so again, this goes back to, and this is a valid statement, and thank you, Jimmy. And this goes back to trust and mistrust in the Black and African American community in the healthcare system. So the healthcare system, public health professionals, and providers have a responsibility to intentionally build trust. But we need more. Again, I think we need more people of color and more people who look like us, who are in these positions and in these fields. And so this goes back to education.
Yeah.
And preparing our children and exposing them to different opportunities. And so I'm glad to have you on as well. My friend, her daughter is interested in medicine, and she's a first generation college student. And when I say medicine, is somewhere in the medical field, and she's still trying to find her way. So this conversation is also important to me, because we get to sit here and we get to model, and you're here and you're a Black woman, you're a pharmacist, and you're educated and you're smart and you're beautiful. And I think this is good for young ladies to see, and even older women as well. But I think it's just to say, oh, you know what, this is a field that I'm probably interested in because of this conversation, so I thank you for that. And then, so Jimmy, also, we won't talk about it here, but your comment also made me think of segregation and desegregation.
Yeah.
And so then that's where we get the structural racism and the systemic racism and all that stuff that comes into play, that is in part responsible for the health disparities that we have in our community. So thank you so much for that. Let's see who else is on. My mother, my number one fan. She says, good morning, and thank you for having this much needed conversation. Very good information for all genders. Thank you.
Thank you.
So COVID-19, what has been the impact on individuals who are HIV positive, who are living with HIV? How has COVID-19 impacted?
So once that community, I mean, there's ongoing studies going on about that, but once the person is undetectable and they're on their meds, they seem to have the same incidences of COVID as, the non-HIV positive population. So I think it would be a concern for that person who is not on medication, and they are like, their CD4 may be lower than 200, their viral load has exceeded 200, right? Because any disease state, any flu, if you got COVID, that would impact you. As long as someone's taking their medication and they're undetectable, they pretty much live healthy lives. But with COVID, what was happening is, like, our facilities actually got shut down. People tested.
Could you backtrack? You said your facilities, your audio went out a little bit. You said your facility.
Oh, okay. So we actually stopped testing in the beginning of COVID. Right. So, our patients who are on prevention medications, they have to get tested 3 months. That's another caveat. So when you're on HIV prevention, you have to get tested every 3 months to ensure that you don't contract HIV. So what was happening is that our facilities shut down, and because of COVID, it's a novel virus, and we were trying to figure it out. So we got shut down. So our patients were not able to come and get tested. So I thought to myself, okay, what are we going to do if we don't keep these patients on medication? We're going to lose them, to retention. So what I did is I advocated with the providers, and I said, look, if these patients are adherent, chances are they need to remain on this medication in case they're engaging in high-risk sexual activity. So what I did was I requested that the provider send a 90-day prescription, regardless of if the patient got tested or not, to maintain them till we got a new normal protocol. So I can proudly say nobody seroconverted. They stayed on the medication. Seroconverted went from being HIV negative to HIV positive. I have to be careful sometimes because I speak that language that, people may not understand because they're not in the field. So seroconversion is when you go from being HIV negative to HIV positive. So what I did was I advocated to keep them on the regimen, and it was very successful because of that retention. When our facilities open, they're able to come back and get tested. So it's so important. It's so important to have this conversation today. And one thing I wanted to add is that our US government actually has an initiative to end the HIV epidemic by 2030. So our goal is to end it by 75% by 2025 and end it by 90% by 2020. And there's actually 4 pillars. First, you want to diagnose, make sure these patients understand that they're HIV, because if they don't know that they're HIV positive, they're going to spread to the community. The second pillar, they want to make sure the patient is treated. Get them undetectable, because treatment as prevention, when you treat somebody, that prevents the spread. And the third pillar is prevention, 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 whether that's giving our patients who are using IV drugs clean needles or putting them on PEP and PrEP. And the last pillar is responding to outbreaks. There's a lot of communities where people are using, in the rural areas, they're using injection drugs and they're sharing the needles. You need to catch that outbreak before it spreads. So this is how we're going to end the HIV epidemic. And there's also a plan to end hepatitis C and also sexually transmitted infections. So it's so important that we all come together. We need to have these conversations in barbershops, in the hair salon, church. I know it sounds taboo, but we need to talk about this in church as well. So vital.
Yes, thank you. And thank you everyone for I'm trying to keep up with your comments, but thank you everyone. For some people just have, just want to comment, like Jacqueline. And Jacqueline, where are you watching from? She says that this is very informative. So by 2030, the U.S. Department of Health and Human Services wants to end the HIV pandemic, and the 4 pillars. And I was writing, so everyone, I have a pet peeve when I watch my shows. And I see myself moving, but I had to write. So diagnose, treatment, prevention, and then respond to outbreaks. And also, I want to mention that when it comes to the opioid epidemic, we do know that it's rampant in rural communities, but it's also occurring in our urban communities and our Black communities as well. And so it's just not in rural only.
And so something else I wanted to add. Oh, I'm sorry.
No, please.
And something else I wanted to add that this program is actually focused in about 48 counties in the nation, San Juan and DC, where 50% of the infections happen. And then there's 7 states that, have a high incidence of HIV infection. So it's actually targeted to a certain cohort. They studied the areas of the United States, and they actually have a dashboard called the AAHIVP dashboard. I don't really recall what the acronym stands for right now, but if you just Google AAHIVP dashboard, you can actually track the improvement, which is an amazing thing. So like anybody who's interested in advocating for this, you can get involved. This is going to be the buzzword starting now until 2020. And, again, there's a lot of stigma associated with HIV, like let's not say someone's HIV positive, let's say a person who's HIV diagnosed instead, you know? Like there's a lot of stigma. A lot of people say it's the gay disease. It is not the gay disease. It can affect anybody. And, you know, even Magic Johnson, which is, you know, someone who, you know, was a celebrity that we watched him suffer from this. He ended up retiring early due to the stigma of it. Once someone takes their medication, they cannot transmit it. So this is something important to know. But another question that's important, let's say that you're with somebody who is HIV positive and they're on their medication, should you take PrEP? That's a personal decision, because if that person ever decides to not take their medication, then they could transmit it to you. So if they're on their medications and remain undetectable, they would not transmit it to you. So that's something else I would like to add that, you know, is an important comment.
Okay. Well, we can just go on and on and on, but I'm going to end the conversation.
Yes.
We talked about a lot of good things. Does anyone have any questions before we sign off? Any questions and if I missed your question, I don't think I did, but if I did, just go ahead and retype it in. I'll give you an opportunity, everyone, to think of some questions to ask, just in case you have anything. Again, this is a great opportunity for us to re-educate ourselves about HIV/AIDS. And just because someone is diagnosed or a person living with HIV, it doesn't mean that they can't have healthy relationships, you know. And I think, you know, we do need to address, you know, a lot of these myths and stigmas. Like you said, it's not a gay disease. Any human can contract HIV, and if someone contracts HIV, it doesn't mean that they're a bad person or that they did something bad. It's just, it can happen, right? And also, if there's this this gossip site, I'm not even going to say the name of it, but it bothers me when they spread rumors and they refer to HIV as the monster. That is not helping. That if I thought that I was HIV positive or I was exposed to HIV, I would be hesitant to be tested, and I would and if I were tested and if I was diagnosed with HIV, I wouldn't want to tell anyone. And then think about the stress and the depression if you label someone as having a monster, you know. So
Right.
we have to be more kind to each other and be mindful of the things that we say, because it can happen to any one of us.
Exactly. Yes, yes, yes.
Okay. Let's see. Jimmy, he agrees with stress, with my analogy or observation about stress. And we have Karen. Karen, I don't know where you're watching from, but she says, great discussion. Thank you, Ms. Shawnta Jackson, for including this on the platform. And Dr. Cassandra Esperant, informative and great energy.
Hi, Karen.
You know her? Do you know Karen?
Yeah, I know her.
Okay. She's in Florida.
Yes, I do.
Okay. Yep. So
yes.
good for
No, she's actually in New York. She's in New York.
Okay, New York. Okay, great. I'm excited about this.
Yes.
And Logan, we have one final question. Logan in Indiana wants to know if you have any thoughts on the new injection medication.
Yes, there's a medication called cabotegravir that's in the pipeline, and the patients would only have to inject every 8 weeks. And yeah, it's definitely promising. I'm excited for other options to be on the pipeline, because what would it do? It would eliminate the issue of adherence, which means taking it every single day to prevent the infection. So as long as they would come in every 8 weeks, get that injection, it would, prevent. It's actually indicated for both men and women. It was recently proven by a study called HPTN 084 that it was, proven effective for women. It's not yet FDA approved, but it's coming in the pipeline. And there's actually in the pipeline also a vaginal ring for women. So there's a lot of options out there, and it does reiterate the need for prevention for us women, not only Black women, all women, but most specifically Black women, because the incidence seems to affect us more. Great topic, Logan, for bringing that up. That was awesome.
So just for clarification, the injection that you can take every 8 weeks that's in the pipeline, is that for individuals who are living with HIV, or is that for prevention? Like for
It's for
individuals?
both, actually.
For both?
For both.
Okay.
Yeah. But the prevention would be taken every 8 weeks. It's not FDA approved yet, but it's been proven effective. It was proven so effective that they actually stopped the studies early. It was 66% more effective. They stopped the studies early because it was so effective. So it's proven to be 66% more effective than the oral. And again, because of the adherence component, right? Like, you know that it's in your system for that 8 weeks. You don't have to like remember to take it every day because.
Okay. And then the ring is pre-exposure, post-exposure is for someone who is living with HIV. What is the what
Yeah,
was
it's
the
for
ring?
prevention. It's for prevention, pre-exposure prophylaxis. Yeah. So
Okay.
it's been approved by the World Health Organization, but again, it's not FDA approved here. But these are things that are coming soon, so we'll see.
Okay. And then I have one question from Jean-Pierre Louise. I think I said that correct. And then I have a question, one final question for you. And so the question is, what's your recommendation on when should one consider taking medication if they are diagnosed with HIV?
Okay, so once someone becomes diagnosed with HIV, it is best to get on treatment as soon as possible because it's been proven that the faster they get on medication, they reach undetectable faster and they remain adherent, which means taking their medication daily. And what does that do? That keeps the patient healthy and it decreases community spread. Great question.
Yes, thank you. And so we have we're on the race for 2030 to end the HIV pandemic, and then we have all of these different medications coming. Can you give us any insight on how close we are to having a cure for HIV?
I mean, they tried that vaccine and it didn't seem to be effective, so I'm not sure. They got the one for COVID together. Hopefully, in the next few years, they'll figure out a plan for HIV. I'm not sure.
And that's fine. And I appreciate that. Again, everyone, thank you so much for joining us on this conversation. I'm Shawnta Jackson, and my purpose in life is to help people to help themselves and others. And you can learn more about me at shawntajackson.com. And you can follow Dr. Esperant on Instagram at the PrEP and HIV Pharmacist. Again, the PrEP and HIV Pharmacist. Follow her on Instagram. And thank you so much, Dr. Cassandra. Thank you so much for joining me today and for this conversation. Thank you, everyone, for watching. I hope to bring in more conversations like this as well. And as always, I'm just very appreciative. So everyone, thank you. And I'll see you next Saturday. And next Saturday, we'll be talking a little bit about criminal reform. Have a great day.